we have discussed the ultrasonic instrumentation of the root canal. This is the root canal that is flooded with irrigant, and this irrigant is sodium hypochlorite, and into this irrigant a file is suspended. This file, when it is ultrasonically vibrated in the range of 25 to 30 kilohertz, ultrasonic instrument, isn't it? There are certain effects that result in increased temperature. We all know that due to ultrasonic vibration, the temperature would be increased, and when the temperature is increased, we know that in a way it would be contributing to heating of the sodium hypochlorite solution inside the root canal. So it would increase the efficiency. EDTA. Now EDTA does not increase the efficiency of sodium hypochlorite. In fact, sodium hypochlorite and EDTA should not be combined together. Okay. Combined together means they should not be used in a combination. They should be used one after the other, not in a combination. EDTA, it reduces the tissue dissolving effect of sodium hypochlorite. We know that the exclusive property of sodium hypochlorite is that it is an organic tissue solvent. So whatever necrotic tissues are present in the root canal are very well dissolved by sodium hypochlorite. But if we are simultaneously flooding the root canal with EDTA also, simultaneously, not one after the other, but simultaneously, then this EDTA would decrease the tissue dissolving effect of sodium hypochlorite, and it would decrease the efficacy of sodium hypochlorite. So the question is asking, which does not increase the efficacy of sodium hypochlorite? Answer would be option C, that is EDTA. Coming over to question number 2. CHX is the standard abbreviation for chlorhexidine. Chlorhexidine is least effective against. We know that normally we use 2% solution of chlorhexidine as an endodontic irrigant. Okay. It is a polybiguanide solution which is used in 2% concentration. It is asking, it is least effective against viruses, gram-positive bacteria, gram-negative bacteria, and yeasts. Now, we know that chlorhexidine, it is a broad-spectrum antimicrobial agent, and it inhibits both gram-positive and gram-negative bacteria. So definitely option B and C, they are correct. That chlorhexidine is effective in killing both gram-positive and gram-negative bacteria. Yeasts and yeast-like fungi like Candida albicans are also killed by this. And viruses, chlorhexidine is effective against only virus with lipid envelope. Okay. So we can say that chlorhexidine has got a limited efficacy in killing the microbes like viruses because they are effective only against the viruses with a lipid envelope. You must remember that viruses can have ribonucleic acid, deoxyribonucleic acid, DNA viruses, RNA viruses. So this chlorhexidine is not effective against DNA and RNA viruses. A very recent example has been the pandemic of coronavirus. We all know that it is a RNA virus, and chlorhexidine has not been effective in killing or these viruses with nucleic acid envelopes. So it is only effective against viruses with lipid envelopes. So it has got limited efficacy. So if we have to make a comparison between the different group of microorganisms that are killed by chlorhexidine, then viruses would be the least affected by chlorhexidine. So answer would be option A. Another set of question could be, what type of viruses are effectively neutralized or killed with sodium or chlorhexidine? Answer would be viruses with a lipid envelope. Okay. Coming over to the question number 3. The interaction of chlorhexidine and sodium hypochlorite forms a precipitate, the amount of which is related to how much of the precipitate would be formed by the interaction. Now, for answering this question, you should know what is the interaction between chlorhexidine and sodium hypochlorite. Whenever we mix them together, chlorhexidine acts like an acid, sodium hypochlorite acts like a base, and there would be an acid-base reaction that forms an insoluble precipitate. Insoluble precipitate that is red to orange in color. And this insoluble precipitate, it is called PCA, that is para chloraniline. So this is the chemical precipitate that is formed different set of questions related to the interaction between chlorhexidine and sodium hypochlorite. Acid-base reaction occurs. This insoluble precipitate would coat the walls of the root canal and it would interfere with the seal of obturation. The obturating materials, the sealers, they would not be able to come in close contact with the wall of the root canal. There would be a microscopic gap that would result in microleakage and potential chances of failure. That's why chlorhexidine and sodium hypochlorite should not be mixed together. Okay. Now, the question is asking something else. The question is asking whenever there is interaction between chlorhexidine and sodium hypochlorite, it forms a precipitate. What precipitate is formed? Para-chloraniline. Okay. And the amount, how much of it would be formed is related to the concentration of sodium hypochlorite. That is something that you have to remember. Okay. So, not the volume of sodium hypochlorite, not the volume of chlorhexidine, not the chlorhexidine concentration, but the concentration of sodium hypochlorite. So no matter the interaction is occurring between two substances, the primary factor responsible for the amount, how much of the precipitate would be formed, is the concentration of sodium hypochlorite. And the higher the concentration of sodium hypochlorite, more the amount of precipitate would be formed. Option B would be the answer to question number 3. Coming over to question number 4. When EDTA is heated from 20 to 90 degrees Celsius, its calcium binding capacity, options are increases, decreases, remains the same, and is not related to temperature. Now, you should remember that heating of EDTA, okay, heating, it would decrease the efficacy of EDTA. It is reverse than that of sodium hypochlorite. With sodium hypochlorite, we have seen previously that its efficiency increases by heating, but the efficiency of EDTA decreases by heating. And efficiency, it is a primary chelating agent, isn't it? Chelating agent means it binds the calcium ions and opens up the root canal up to about 50 micron depth. The depth of action is nearly 50 microns inside the wall of the root canals. So whenever we are using this chelating agent, it has a calcium binding capacity, and if we use a heated solution of EDTA, its calcium binding capacity would decrease, that is reverse of that of sodium hypochlorite. Option B is the answer. And this EDTA solution that is used has a pH value of, it is a slightly alkaline solution, 7.2 to 7.3, and it is usually used in a 17% concentration. Okay. These are some of the facts related to EDTA as a root canal irrigant. Coming over to question number 5. The time required for removing the smear layer with EDTA is 1 minute, 2 minutes, 3 minutes, or 5 minutes. This is something that you have to remember. And when I discussed this aspect of root canal irrigation in one of the previous sessions, I have specifically told you that there are two standard set of questions related to smear layer management. See, technically speaking, smear layer consists of both organic and inorganic portions. So we require two set of agents to remove the organic and the inorganic part. The organic part is taken care of by 5.25% sodium hypochlorite, and the inorganic part is removed by 17% EDTA. So combination of these two irrigants is used, and the time required in a standard protocol is 2 to 5 minutes. So this is the first step. We flush the root canal with 5.25% sodium hypochlorite, and after that we do it with 17% EDTA. So respectively the organic and the inorganic portions of the smear layer are removed, and the standard time is 2 to 5 minutes. This is one set of question. Here it is another set of question. The question is simply asking you the time required for removing the smear layer by EDTA. It is not mentioning anything about sodium hypochlorite. So for that, you have to remember that it would be 1 minute. Option A would be the answer to the question that is asking. Directly EDTA has been asked, 1 minute would be the answer. Remember that. Question number 6. All are effective in removing the smear layer except Qmix, BioPure, Tetraclean, and Usol. What is Qmix? Qmix is a mixture of chlorhexidine isomer, that is triclosan plus EDTA. So it is a mixture of two substances, triclosan and EDTA. BioPure, it is also called MTAD. It is based on tetracycline, citric acid, and detergent. So due to the presence of citric acid, it is effective in removing the smear layer. Due to presence of EDTA, Qmix is effective in removing the smear layer. Similarly, tetraclean is another antibiotic-based irrigant that is also based on tetracycline plus detergent. So this detergent is also helpful in removing the smear layer. Usol is a solution based upon saline, etc., and it is not effective in removing the smear layer. So answer to this question would be option D. Option A, B, and C all are individually capable of removing the smear layer. Okay. And another thing that you can remember about these options A, B, and C, that is Qmix and these two antibiotic based irrigants, that is BioPure and Tetraclean, is that all three of them, they are used as final irrigant. If we are using a combination of substances, they should be used as a final irrigant so that they are not only antimicrobial because of their triclosan or antibiotic content, but they are also helpful in removing the smear layer from the wall of the root canals. So they are used as a final irrigant. They would be the last substance to be used for flushing out the root canals. Coming over to question number 7. Not a limitation of calcium hydroxide as an intracanal medicament. Not a limitation means what this is dealing with the limitations of calcium hydroxide. It is ineffective against Enterococcus faecalis. Definitely it is a limitation of calcium hydroxide that it is not effective against E. faecalis. E. faecalis is a gram-positive cocci, which is principally found in cases of failed root canals. It is found in the cases of failed root canals. Okay, so definitely this option A is a limitation of calcium hydroxide. incomplete removal from the root canals. What does it mean? When do we use calcium hydroxide? Calcium hydroxide is an intracanal medicament that is used usually for 1 week or so for sterilizing the root canal, especially the root canals that we are not able to achieve complete dryness with. Okay, so to make the root canal sterile and dry, we put an intracanal medicament of calcium hydroxide. And definitely, since it is an intracanal medicament, before obturation, we have to remove the calcium hydroxide. But a disadvantage of putting calcium hydroxide inside root canal is that it cannot be completely removed by any of the available methods currently. If we are flushing with saline, we are flushing the root canal with sodium hypochlorite, we are doing ultrasonic agitation, we are using mechanical instrumentation. No matter what method of removing the calcium hydroxide we employ, complete removal of the calcium hydroxide from the root canal is not possible, and 30 to 40% is residual calcium hydroxide in majority of the systems. So we can see a significant amount of calcium hydroxide remains inside the root canals. And because of this residual calcium hydroxide, what is the disadvantage? Firstly, it would interfere with the seal of obturation. And secondly, if we are using a zinc oxide eugenol based sealer, different type of sealers are available. If we are using a ZOE based sealer, the setting of such sealer would be hastened. Means that sealer would set very fast on interaction with residual calcium hydroxide. So definitely it is a limitation. Option B. It can fragilize the dentine. Okay. Yes. Long-term calcium hydroxide. Long-term calcium hydroxide dressing for cases of epexification. We all know that the traditional method of doing epexification has been calcium hydroxide for long term. For cases of avulsion, to prevent the root resorption, we give calcium hydroxide dressings. So in such clinical situations, what happens? This long-term calcium hydroxide dressing, it reduces the flexural strength of dentine. They would make the root of such teeth susceptible to fracture under masticatory load. So definitely they fragilize the dentine and make the tooth susceptible to fracture. So this is a limitation also. Now coming over to option number D, hydrolyze the bacterial LPS. So it is basically the mechanism of action. Whenever gram-negative bacteria are present inside the root canal, they have a virulence factor. The gram-negative bacteria have a virulence factor of lipopolysaccharide. The cell walls, they contain a virulence factor that makes them pathogenic, isn't it? So calcium hydroxide has a positive effect of inhibiting the lipopolysaccharide of gram-negative bacteria. So they inhibit the growth and multiplication of gram-negative bacteria. So option D is not a limitation, but it is an advantage of calcium hydroxide. It is not false. All the options are true about calcium hydroxide. But the question is not asking which is not true. The question is asking which is not a limitation of calcium hydroxide. So option D is an advantage. So is the answer over here to this question. I hope all of you understand that. Okay. Question number 8. Not a property of ladder mix paste. Now, what is a ladder mix paste? You should know that to answer this question. Ladder mix paste is a mixture of 3% demiclocycline, which is an antibiotic, a tetracycline isomer, and 1% triamcinolone. acetonide, which is a steroid and anti-inflammatory agent. So this ladder mix paste is basically used in conditions of inhibiting tooth resorption. This is the principal effect of ladder mix paste. So whenever we encounter a clinical situation where root resorption or tooth resorption is likely, what would be the intracanal medicament of choice? Ladder mix paste. So which is not a property. It is a non-setting water insoluble paste. It inhibits bacterial protein synthesis. It is used for direct and indirect pulp capping, and it prevents root resorption. This we have already seen. So definitely option D is correct. It inhibits bacterial protein synthesis. Option B is also correct. It is the mechanism of action of ladder mix paste. Okay. It is used for direct and indirect pulp capping. Yes, it can be used for direct and indirect pulp capping. The primary use is for cases of tooth resorption, but it can be used for cases of direct and indirect pulp capping. It is a non-setting water insoluble paste. This option is partially incorrect. It is a water soluble paste, not insoluble paste. It is a non-setting water soluble paste. So option A is a partially incorrect option. So A is not a property of ladder mix paste. So ladder mix paste is a mixture of antibiotic and a steroid that is primarily used in cases of tooth resorption. It can also be used for vital pulp therapy like direct and indirect pulp capping. Its mechanism of action is that it inhibits the ribosomal protein synthesis of the bacteria, and it is a non-setting water soluble paste, not insoluble. Option A would be the answer here. Okay. Question number 9. A potential disadvantage of intracanal antibiotic paste is potential disadvantage. Antibiotic paste, if you remember, what is the most typical antibiotic paste that we used? We use a triple antibiotic paste. As an intracanal medical, isn't it? A triple antibiotic paste is used. So potential disadvantage of this is it is not effective against aerobes. Triple antibiotic paste is a mixture of ciprofloxacin plus metronidazole plus minocycline. And they are usually present in the ratio of 1:1:1. So since it is a combination of multiple antibiotics of different groups, they are effective against both aerobes and anaerobes. So not effective against aerobes is not the disadvantage. It is effective against aerobes. It is difficult to remove from the canal, may cause bacterial resistance, and it interferes with the seal of obturation. See, it is not difficult to remove from the root canal. What intracanal medicament is difficult to remove from the root canal? Calcium hydroxide is difficult to remove from the root canal, and not triple antibiotic paste. Triple antibiotic paste can be easily removed by flushing with sodium hypochlorite from the root canals and gentle mechanical agitation. So when it is completely removed, the related thing is that it interferes with seal of obturation. No, when we are able to remove it completely from the root canal, it would not interfere with the seal of obturation. So option D is also not correct. It may cause bacterial resistance is a correct answer over here. We are using a combination of antibiotics. This combination of antibiotics is usually given up to 3 to 4 weeks or maybe longer in certain cases. And because of this long usage of a combination of antibiotics inside the root canals, there are some potential that it can cause bacterial resistance. So the question is asking which is a potential disadvantage. Option C is a potential disadvantage of using triple antibiotic paste inside the root canal. Answer would be option C. Coming over to question number 10. The multisonic irrigation system is endo activator, rinse endo, gentle wave, and PUI. PUI is a standard abbreviation for passive ultrasonic irrigation. Now, to answer this question, you should remember what are the different modes of agitation of irrigant inside the root canals or delivery of irrigants inside the root canals. The most common and the simplest method is syringe delivery of irrigant inside the root canal. For that, we use a small gauge of needle like 30 gauge or 27 or 29 gauge of needle deliver the irrigant inside the root canal. Now, let us see. The question is asking you about multisonic. Multisonic means different sonic waves it uses. Endo activator, rinse endo, gentle wave, and passive ultrasonic irrigation. See, rinse endo is a irrigation evacuation system. It is an irrigation evacuation system. Means there is a constant flushing of the root canal by way of delivery of irrigant inside the root canal and removal from the root canal. Irrigation evacuation system. Rinse endo. Rinse endo works under negative pressure. Negative pressure irrigation of the root canals. Gentle wave. Gentle wave is a multisonic method of irrigation. Endo activator is a subsonic method of irrigation. It produces subsonic vibrations. Okay. Gentle wave, multisonic vibrations are generated, which is a computer controlled irrigation system. It is a modern device for flushing out the root canals by way of a computer controlled system called gentle wave, and it works on multisonic multiple frequencies of vibrations are given, computer controlled system. And PUI stands for passive ultrasonic system. So ultrasonic, subsonic, and multisonic. Three modes of sound waves are used for different irrigation systems: subsonic, multisonic, and ultrasonic. The example of subsonic is endo activator. Example of multisonic is gentle wave. And example of ultrasonic is passive ultrasonic irrigation. And what is rinse endo? It is not related to sonic frequency. It is an irrigation evacuation system that works under negative pressure irrigation of the root canals. Question is asking you multisonic. So what would be the answer? Option C, gentle wave would be the answer over here. Coming over to question number 11. APDT uses laser of what wavelength? What is APDT? APDT stands for activated photodynamic therapy. It is a method of use of laser for disinfection of the root canals. It is also called photo-activated therapy or simply PAD. Okay. It has got two aspects. One is a photosensitizer. Photosensitizer, a dye or liquid injected inside the root canals, which is photosensitized. The most commonly used is toluidine blue dye, that is abbreviated as PBO. So if this is the root canal that we want to disinfect, in the first step, we would inject a photosensitizer dye that sensitizes the microbes inside the root canal to the action of light. And the second is we use a laser light. Mostly we use diode lasers. Okay, diode lasers, we use red lasers. And what is the red region of the visible spectrum? In the range of 600 to 700 nanometers. Red laser is used. So if we look at the wavelengths given over here, 2940, 2790, 248 and 680 nanometers, what will be the right answer? This red laser is used. Option D would be the answer for activated photodynamic therapy or photoactivated disinfection. What it is? It is a method for disinfection of the root canals by using a red laser. We firstly sensitize the bacteria by injecting a dye inside the root canal. This dye coats the bacteria that are present in the root canal, and when subsequently we fire laser inside the root canal, the energy of that laser is absorbed by the dye, and where the dye is present on the microbes, so microbes get killed. It is like a paintball game. Okay, you must have played paintball game. We see the target, we hit it with a paintball, and the target is marked. Similar thing is happening. We are injecting a dye to mark the targets that are killed by the laser light. So what laser is used? Red laser is used. If we look at the wavelengths, these wavelengths are the commonly used lasers inside dentistry, 2940 nanometers. It is a erbium YAG laser. 2719 nanometers. It is erbium chromium YSGG laser. 248 nanometers is a xenon chloride laser, excimer laser. Excimer laser. Excimer lasers are special ultraviolet lasers. Examples are argon fluoride, krypton fluoride, and xenon chloride. Okay, so these are the different types of laser wavelengths. More specifically, you can remember it is for krypton fluoride, KRF. Yeah, type of excimer laser. What are excimer laser? They are special ultraviolet lasers. Okay. Coming over to question number 12. The light walker is a device for. It is a brand name of the commercially available device that is given over there. Light walker. It is a device for curing of composites, caries diagnosis, laser activated irrigation, or laser assisted tooth bleaching. Now, light walker, it is a laser irrigation system. That is something you have to remember. Okay, it uses a low energy erbium YAG laser. What is the wavelength of erbium YAG laser? 2940 nanometer. We have just seen in the above question. And it is important for you to remember the wavelengths also of these commonly used lasers. Okay, so it is used for laser activated irrigation of the root canals. Option C would be the answer. Now, if this is the tooth that we are doing root canal with, after gaining access to the pulp chamber, these are the root canal orifice. The root canal, pulp chamber, and the orifice, they are flooded with sodium hypochlorite irrigation. And there is a laser tip that is placed inside the pulp chamber filled with sodium hypochlorite. What laser is used? Erbium YAG laser at low energy. Low energy means 0.1 to 0.3 watt. Low energy is used. Okay. This laser energy would agitate and activate the fluid present inside the pulp chamber. What is the fluid present? It is sodium hypochlorite, and this method is technically called PIPS. The technique is called PIPS, that is photon induced photoacoustic streaming. Photon-induced photoacoustic streaming. This phenomena of agitation of liquid inside the root canal by way of laser energy is called PIPS, photon-induced photoacoustic streaming. And an example of a commercial product available that works on this technique is Lightwalker. So these are some of the things that you have to remember about the device called Lightwalker, and it is used for laser activated irrigation. Option C would be the answer here. Question number 13. The antibacterial nanoparticles used in endodontics have a size of, okay, antibacterial nanoparticles like chitosan. Okay, these are the commonly used nanoparticles that are used in endodontics. Now, nanoparticles. For this, you have to remember that they have a size in the range of 1 to 100 nanometers. Now, all the options are given in nanometers, so please do not get confused. This is something that you have to remember. So, what is the average size distribution of nanoparticles? It would be in the range of 1 nanometer to 100 nanometer. Option B would be the answer over here. There are certain things that you have to simply remember. Okay, this is one of those. Question number 14. Intralight disinfection uses another commercially available product. Now you can see that a lot of questions have come or are related to the commercial names of the devices that are available, like endo activator we have seen, gentle wave we have seen, light walker we have seen. Another product is Intralight. So you should know the prominent brand names like these and what actually they are working upon or consisting of, isn't it? So Intralight uses ozone, UV light, excimer laser, or diode laser. Intralight is as the name indicates, is a light-based disinfection system for the root canals, and it uses ultraviolet light of 254 nanometer. So option B would be the answer. Ozone is ruled out by the suffix light, and excimer laser and diode lasers are not related to this device. Intralight is a disinfection device that uses ultraviolet light. You know that ultraviolet light is a potent disinfecting agent. You must have seen in the clinics there are ultraviolet chambers. At the time of COVID, there have been a rampant use of ultraviolet bulbs and lights inside the operatory to disinfect the environment of the operatory, isn't it? So it is a potent microbicidal agent. And similarly, we can disinfect the root canal that is potentially laden with microbes, pathogens by using a ultraviolet light of 254 nanometer. So another question is, what wavelength of ultraviolet light is used? It is 254 nanometer, and the device is commercially called Intralight. The next set of questions, they are related to another topic, that is obturation, that has already been covered in some of the previous sessions. Okay. The question number 15 for today's session is the first question related to the subject of obturation. Single visit endodontics is acceptable in all situations except. Okay. It is asking in which clinical diagnosis or condition we would not prefer doing single visit root canal. Painful irreversible pulpitis, chronic apical abscess, acute periradicular abscess, or asymptomatic apical periodontitis. Now, the patient is reporting with spontaneous pain due to irreversible pulpitis. There's a case of painful irreversible pulpitis, and like a multi-visit root canal treatment, we can easily do a single visit RCT with a case of symptomatic or painful irreversible pulpitis. So it is acceptable in option A. Chronic apical abscess. There has been a tooth. When you take a radiograph, you see a well-defined radiolucency suggesting of chronic apical abscess. At times, there can be clinical sinus formation. So looking at the sinus should always give you a favorable diagnosis. Sinus should not frighten you. It should give you a favorable condition because body has already formed a pathway for drainage of exudate and abscess. So this is also conducive easily to single visit endodontics. Acute periradicular abscess. Against apical abscess that is chronic, acute abscess has usually got no radiographic evidence. It has developed and no radiographic evidence is there. And these are extremely painful conditions. It is best to avoid single visit endodontics in cases of acute periradicular abscess. Asymptomatic apical periodontitis means there's inflammation of the PDL. The patient is not symptomatic. We can easily do single visit as compared to multiple visit. So looking at the clinical options over there, you have to remember this. Acute periradicular abscess is least acceptable out of the conditions over here. I'm not saying it is contraindicated in cases of acute periradicular abscess. The question is asking you, it is acceptable. Accept means not as acceptable as other clinical diagnosis. So I would again stress that there is no absolute contraindication for single visit endodontics, but there are relative conditions where we find that it is potentially less acceptable as compared to multiple visit procedure. So one of the condition where it is less acceptable is acute periradicular abscess. Option C would be the answer. Question number 16. The prognosis of root canal treatment is not significantly affected by. What are the factors that significantly affect the prognosis of RCT? The quality of root canal seal, the quality of coronal restoration, the type of coronal restoration, and number of treatment visits. Now, it is a very interesting question related to the clinical scenario. Definitely, the quality of root canal seal would have a positive influence on the outcome of root canal treatment or prognosis. The quality of coronal restoration is equally important. A very good root canal without a good fluid tight coronal restoration is of no use, and the root canal would fail in as less as 6 months of duration. So not only we should focus upon the good quality of three-dimensional fluid tight seal inside the root canal, but the coronal restoration placed immediately after obturation is equally responsible for the prognosis. So both A and B are true. The type of coronal restoration. Type means whether you give a zinc oxide eugenol restoration or you give a composite or a GIC restoration does not significantly affect the prognosis unless it is a fluid tight seal. Okay, so the restoration should be such that it creates a fluid tight seal, whether it is GIC or composite or any other amalgam or any other restorative material. If the seal is fluid tight, it would not significantly affect the prognosis. Okay, number of treatment visits. Okay, is it significantly affected by treatment visits? No, this is also not significantly affected. That's why I told you that it is a very good question. Now we are confused with option C and D. Okay, Single visit versus multiple visit RCT, there's no significant difference in the treatment outcome. Okay, now what to choose? Which is a better answer over here? Although both C and D would not significantly affect the prognosis, if we have to make a strict comparison, option C is a better answer as compared to option B. Okay, sorry. Option D would be a better answer as compared to option C. I'm sorry for this. So, answer to this question, we would prefer D, that number of treatment visits is less significant as compared to the type of coronal restoration. Definitely, if we make a strict comparison between different restorative materials, then owing to their properties like solubility and strength, some restorative material would better seal the root canal for longer duration as compared to other materials. Okay. So, strictly speaking, the type of coronal restoration do have some influence on the outcome of treatment, significant, and least influences by the number of treatment visits. So option D is a better answer over here, or is the preferred answer. Question number 17. Not a property of ZOE sealers. Which is not a property. Always look for these small marker words that make you directly asking a property, not a property, all except. So these marker words should be carefully read in the question. It resorbed if extruded in the periradicular tissues. Yes, zinc oxide eugenol has advantage that to an extent it is resorbable when it is extruded beyond the confines of the root canal. Shrinkage on setting is a property. They have a contraction potential in the range of 0.1 to 0.4% contraction of zinc oxide eugenol based sealer happens inside the root canal. Delayed setting with calcium hydroxide medicament and can stain the tooth structure. Yes, they have a potential to stain the tooth structure, zinc oxide eugenol. Now, this is something that we have already discussed in today's session previously, that when we talked about residual calcium hydroxide inside the root canals, we know that a potential disadvantage is that this residual calcium hydroxide hastens the setting of zinc oxide eugenol based sealers. So there is not delayed setting, but there is rapid setting of ZOE based sealers when they are combined with calcium hydroxide. So option C is not the property of ZOE based sealers. Coming over to question number 18. Following is a fourth generation methacrylate resin based sealer. Fourth generation. Okay. Methacrylate resin based sealers are divided into first, second, third, and fourth generations. The first generation materials, they are used without core material. Means we would simply obturate the root canal with the sealer only. An example of this first generation is Hydron. Second generation, they are used with or without core material. What is core material? We use two things for obturation of the root canal. One is a core material like a taparcha cone and sealer all around it. So in the first generation, we are not using any core material, simply obturating the root canal by filling it with sealer. The second generation can be used either with or without a core material. The choice depends upon the clinician. An example of this sealer, that is methacrylate resin based and categorized under second generation, is ENDO rays. The third generation products, they are based on Self-etching primers. SEP stands for self-etching primers. If you remember dentine bonding agents, they are the basically sixth generation dentine bonding agents. Self-etching primers. Okay. Now these self-etching primers based third generation methacrylate resin-based sealers are Real Seal, okay, and fourth generation they are based on self-etch adhesives, self-etch primers, self-etch adhesives, or seventh generation dentine bonding agents. Example of this product would be Real Seal SE, suffix SE is there, okay, and Metaseal. These are two examples of your fourth generation, example of third generation, example of second generation, example of first generation. This is something that you have to remember. Question is asking you about fourth generation. Answer would be Real Seal SE. Resilon is not related to methacrylate resin-based sealer. Real Seal would be third generation. ENDO is second generation. Real Seal SE fourth generation. Answer option D. Question number 19. According to ISO 6876-2001 requirements, an endodontic sealer should have a film thickness of. Now, these are according to standard requirements for the endodontic sealers according to ISO number this or ADA specification number 57. Both you can remember that sealers are covered by ADA specification number 57 or ISO specification number this. The film thickness of the sealers should be less than 50 microns. Option B would be the answer. Okay. Other requirements, one is for film thickness, solubility. According to this ISO specification, solubility of the sealer should be less than 3% by weight. Another requirement is of radio opacity. It should be about 3 millimeter thickness of aluminium. Radio opacity of the sealer. Dimensional stability. I am telling you the requirements according to ADA specification number 57 or ISO 6876-2001 for the endodontic sealers. The first film thickness we have seen should be less than 50 microns. Second, solubility should be less than 3% by weight. Radio opacity should be equal to or greater than 3 millimeters of aluminium. Dimensional stability. It should not expand or contract beyond a certain range. It should be in the range of minus 1% to 0.1%. It should not contract or expand beyond this range. And it should not expand or contract. It should not contract more than 1%. It should not expand more than 0.1%. And final is flow. The sealer should be fluid enough to flow and cover maximum possible area of the root canal should be greater than 20 millimeters on the wall of the root canal. These are the 5 standard requirements for sealers according to ADA specification number 57 and ISO 6876-2001. Question number 20. The best sealer distribution on the walls of the root canal is achieved by sealer distribution. Means maximum coverage of sealer on the walls of the root canal. with a master cone, with lenticular spirals, files and reamers, or ultrasonic? It would be ultrasonic. Whenever we do ultrasonic compaction of the sealers, the most common instrument used are lenticular spirals and files and reamers, but they cover only about 62.4% surface. With these methods, A, B, and C, maximum coverage is just 62.4% of the surface area of the root canals. To enhance the coverage, to make the sealer more evenly distributed, maximum coverage, no area of the root canal should be left without sealer. You should use ultrasonic agitation and compaction that would greatly enhance the sealer coverage. So, option D would be the answer over here. Question number 21. All are true for warm vertical compaction obturation technique except warm vertical compaction, which is not true. All are true except the master cone is fitted 0.5 to 2 millimeter short of the working length. Yes, it is true, because whenever we are using warm vertical compaction, if this is the prepared root canal, then we would choose a master cone that sits 0.5 to 2 millimeter short of the working length, so that whenever the pressure is applied by a heated plugger, the master cone would melt and it would flow apically and laterally. If we are keeping it to the working length, it would flow beyond the apex. The forces developed are nearly equal to lateral compaction is also correct. Both are methods of using a hand instrument like a spreader and plugger. So the forces that are applied for obturation are equal in the techniques of cold lateral and warm vertical compaction. Less length control than with lateral compaction. Definitely, in a lateral compaction method, cold lateral compaction method, we are using a solid form of gatta parcha that can be very well seated to the prepared working length. But when we are using a warm vertical method, although the gatta parcha would melt and flow apically and laterally, how much would be the length of penetration is not under the direct control of the clinician. So, length control is poor as compared to cold lateral compaction. This option is also correct. The gatta parcha adaptation is better in wide canals compared with small canals. No, the reverse is true. Small canals, it is better. Wide canals, it is poor. Okay, something you have to remember about warm vertical compaction. So option D is not correct. For narrow canals, the gatta parcha would flow and distribute evenly as compared to wide canals. In wide canals, the gatta parcha would melt, but it is highly unlikely that it would cover the entire surface in a uniform manner. There would be potential for voids more as compared to narrow canals. So, gatta parcha adaptation is better in small canals and poor in wide canals. Is the right thing. As our option is listing reverse, option D would be the answer over here. Okay. So with this, I conclude today's session of MCQ. See you again next Wednesday in another interesting round of MCQs related to the subject of cons and endo. Till then, happy reading. Good night, all of you. Please take care of yourself and happy Independence Day from my side. Best wishes. Thank you so much for being connected. Good night.